So bipolar disorder is well described ever since humans started writing down about their own experiences. And then why it suddenly switches from high activity mania to low activity, low energy depression. So they switch that on off and switching from one to the other. Truth is, we don't know.
G'day and welcome to Wellbeing. I'm Jack Hodgins. Today we are talking with Professor Ian Hickie from the University of Sydney about bipolar disorder. This is the second instalment in our series on bipolar disorder. Professor Hickie is the co-director of Health and Policy at the University of Sydney's Brain and Mind Centre. He is also an internationally renowned researcher in clinical psychiatry, with a particular interest in mood disorders such as bipolar disorder. In this episode, we get an overview of bipolar disorder, but also a deep look into how the body's internal clock connects with bipolar. Hello Ian, and welcome to Wellbeing.
Thanks for the opportunity.
Many have heard the term bipolar, but what is a bipolar disorder?
Well, it has two phases of a major mental health problem. One is a high phase or an activation phase, and you're being overactive, can't sleep, making all sorts of bad decisions. One, and that's what is classically seen as the manic phase or the overactivity phase. And then there's another opposite to that, which is a low energy, low activation, depressed phase. So when people talk about bipolar, they talk about being at one end or the other of that mood, activity, sleep-wake cycle type spectrum. Classically called manic depressive illness, but these days referred to more commonly as bipolar disorder.
I mean, you highlighted those phases that people go through, but what are there different types of bipolar, like such as bipolar 1, bipolar 2?
So there have been many attempts to subclassify bipolar disorder between the more severe forms, so classically bipolar 1, where there's absolutely clear-cut manic episodes. People really do lose the plot. They're so overactivated, they can't sleep, they're active all the time, they're making bad decisions, they may become psychotic, they may develop very grandiose ideas and do very inappropriate things, and quite often get hospitalised, certainly get medically treated. And that's the characteristic of so-called bipolar 1. That's clear-cut, runs strongly in families, usually requires serious medical intervention and has big impacts on people's lives. Other people have periods where that kind of increased activity, that increased energy, that sleep-wake cycle disturbance isn't as prolonged or as severe. And so periods of so-called less mania or hypomania, like less significant, but also associated with recurrent depressive periods or very unstable mood. So people often refer to that as bipolar 2, implying a less severe but also recurring type illness with these same kind of on-off and switch-like phenomena and unstable mood. And then people have proposed various other variations on that, is where people's mood are up and down or their sleep-wake cycles go up and down in various sets of ways. So there's some attempts to separate out the most severe, the most clear-cut, that which runs most strongly in families, from other sorts of common mood, and particularly unstable mood, and unstable periods where people have this very much this off-on phenomena. They have bad periods, but then they come good, or they switch from high activity to low activity states.
And what are those high elevated activity states like? I mean, those manic episodes, like what's kind of going on?
Well, we see what's happening. The person's full of energy, running around, often disinhibited, often doing things they wouldn't normally do, spending money, sticking their nose into things they wouldn't do, making grandiose plans, engaging in sexual and other relationships they wouldn't engage in, and really losing most of those normal social inhibitions, most of those restraints that have, allow us to live normal social lives. And that creates huge amounts of difficulties in the workplace, in relationships, in the social sphere. So it can look like the person's having a great time, or it can look like the person's very energetic, and the person themselves might feel it's the most important period of their life. They're suddenly doing the most important things. They're suddenly saying all the things they really should have said. They're doing things that they would not normally do at all. But of course, it's not their normal self. It's a loss of control over their normal planning, appropriate social behaviours, interactions with others, and the sort of judgments that they would normally make about the appropriate behaviour in the right social circumstances. I mean, it's an interesting thing because some aspects of it, at least when it's not very severe, are kind of attractive. Being energetic, having a plan, feeling there's a purpose to life, engaging in new relationships, can sort of be fun. Or can appear attractive or appear to others that the person's really just off on their own trip and not taking consideration of others. And can appear, selfish, or it can appear very self-centered. But in fact, for most people, it's not very pleasant at all. It's really difficult, causing lots of troubles. And the idea that people are necessarily enjoying the whole experience is also not necessarily true. It can be very dysphoric, it can be very unpleasant and get people into lots of difficulties. What's
kind of going in the brain to make that happen? Like what's happening in the brain pathways?
Well, we wish you knew the answer to that exactly. So clearly, those brain pathways that drive activity are supercharged, are turned on, and they're not doing what they should normally do in your 24-hour sleep-wake cycle. That is, you should have a normal amount of energy, particularly in the mornings, early in the day, a bit slower around lunchtime, pick up again in the afternoon, and then turn off in the evening. And you should have a fairly regular pattern of that day to day in a regular 24-hour cycle. So it's supercharged during the day, not turning off at night, and actually exhausting you physiologically. So it's actually physically dangerous to be in that state for a prolonged period. And the normal 24-hour cycle is disrupted and the normal day-to-day regularity is gone. It's kind of interesting because it's the thing which switches itself often at certain times of the year. When the seasons switch, it's lost its normal responsiveness, the normal life cycle that changes with seasons. It's off on its own trip.
Yeah, and would you say with those elevated moods, like when in terms of the brain pathways, is it being affected similar to how it would be affected if, for example, if someone was taking drugs, like was getting that elevated feeling?
Yes. So the drug equivalent is taking lots of amphetamines, lots of stimulants to wind you up, make you full of energy, not go to sleep. And because we know amphetamines release dopamine in the brain, and dopamine's tied up very much with motor activity. When you don't have enough, you get Parkinson's disease. When you have too much, you run around in circles. You're not very purposeful kind of activity, just supercharged and often very agitated. And we know that if you block those dopamine pathways, so a lot of the treatments for acute mania try to block those pathways, you can slow people down again. So they look to be those pathways that are relevant, dopamine being one of the most relevant chemicals to activation of those pathways. But what really sets the whole thing off, and then why it suddenly switches from high activity mania to low activity, low energy depression, so they switch that on-off and switching from one to the other, truth is, we don't know. We don't know how that actually happens. We just know that we all have normal switches. Just the most normal switch we all experience is that between daytime wakefulness and nighttime sleep. That's a normal circadian body clock. So we know we have these clocks in our head. We know they run to certain patterns. Why they go off and why they develop this very unstable pattern in bipolar disorder, in truth, we don't know.
Along with the elevated moods, there's also the depressive moods, which is like the complete opposite of those elevated moods. I mean, what's kind of going on when that's happening?
Well, if you think of those as the reverse, or the other side of the coin, and hence the bipolar type name, from the high activity state, elevated mood, lots of energy, lots of activity, to the opposite, low activity, low energy, prolonged sleep, overwhelming fatigue, can't get anything done, and very low mood in association with that. That's the depressed phase. Interestingly, in the past, people didn't really emphasise the depressed phase because it's the manic phase that causes all the social trouble that everyone else notices. If you're lying in bed at home on your own, not causing anyone trouble, people didn't tend to notice. But in actually longer-term studies of what really messes with the lives of people with bipolar disorder, many said it was the depressive phase that was much worse. Much worse to have no energy, no motivation, no sexual drive, no pleasure from anything, and be sleeping all day and feeling, I just can't do anything, and be horrible to be stuck in that phase. And what's also really difficult is the treatment of that depressed phase in bipolar disorder is not easy. It does not respond as well to our antidepressant treatments as more common garden variety, other forms of anxiety and depression, which do quite well with our available treatments. So bipolar depression remains one of the big therapeutic challenges in mental health care.
I mean, do we have any idea about why it's happening? Like, have we got any research into that, or like, what is it kind of saying?
Well, we know bipolar disorder, certainly bipolar 1, runs strongly in families. So part of the process is genetically determined, and it grows equally in men and women and runs fairly strongly in families. So people in those families inherit a likelihood. Now, we know that plays out in these very unstable body clocks, these 24-hour circadian rhythms. So we know that those are unstable in people with bipolar disorder even when they're well. And they're easily perturbed by things like changes in seasons or life stresses or taking drugs. There are things that can set them off in certain situations. So we know that's happening alongside. There's a bit of a chicken and egg argument as to what the cause is or what is the consequence once you're in that state, what continues to perpetuate it or cause it to recur. So a lot of work at the moment is, look, we know there are genetics involved. We know there's some critical brain circuits. We certainly know there's some critical brain systems like the circadian system that are perturbed. But like most brain science, we're better off at describing what is happening than really providing a true understanding of the process that is driving it.
How prevalent would you say all this is, the bipolar?
So we know that the bipolar 1 type disorders affect about 1 to 2% of people in their lifetime. So they're not that common, but they're not that uncommon either. That's quite a lot of people. And even with severe bipolar disorder, a significant proportion of people don't receive treatment and certainly don't receive effective treatment. So their lives are really messed, and a lot of people will end up in trouble with drug and alcohol problems, trying to manage it themselves, or ruined relationships, or trouble with the law, or other sorts of difficulties. So historically, only those with the most severe problems have been treated. Now, you raise the issue of bipolar 2 or less severe forms of illness, and people might have recurrent manic episodes or live in a community with persistent depression. So there's probably another 2 or 3% of people that are part of the bipolar spectrum of illnesses, very unstable mood, recurrent depression, brief periods of activation or hypomania. So in total, you're talking about somewhere around 2 or 3 or 4% of the community that are affected at some stage in their life.
You're listening to Wellbeing, a nationally distributed radio show and podcast. My guest today is expert Dr. Ian Hickie from Sydney University, where we are discussing bipolar disorder. What is the usual onset for it? Like, how old are people when they're getting it?
So interestingly, more and more work's gone into that. There's an interesting thing. The characteristic features of depression and then periods of motor activation or the high periods start to emerge in adolescence. Now, a significant proportion of those people will have had anxiety or other sleep-wake cycle or other difficulties as children, but very unclear as kids that any of those kids would go on to have bipolar disorder, because those other problems are very common. We don't know which one. But in adolescence, you start to see this change in sleep-wake cycle, change in mood, activation. And then diagnostically, that becomes typically clearer in late adolescence, when you might see the first manic period, certainly in boys. In a lot of women, there's also another risk period, which is around the birth of their first child. So typically we say the age of onset are like 18 to 25. But for women, there's another risk period, and that's around the birth of the first child. So we often see after the first birth, in that postpartum period, the first episode of mania or very severe depression in women with bipolar disorder. And that's interesting because clearly childbirth is not only a major hormonal event, but one that really disrupts your sleep-wake cycle. And that may be the precipitating factor.
Yeah, that's an interesting point there, Ian. I mean, the sleep-wake cycle, is that and you touched on that earlier too. I mean, that seems like that's a really big part of bipolar just generally. So
I would say, and the people at work I'm associated with and research, we would say that is the culprit. That's the big factor that underpins. That's the thing that's characteristic. Is this switching from high to low activity states, the change in the sleep-wake cycle and the way it's unstable and easily perturbed by life stress, by jet lag, by flying overseas, by taking drugs, by changes in seasons, by childbirth. We tend to, in the work I'm associated with, point our finger at that as the central figure. And it's interesting that the best treatments we have, and one discovered in Australia, lithium carbonate, actually stabilises the sleep-wake cycle, the circadian clock, makes it less likely to drift all over the place. And so it's the best preventative treatment we actually know for preventing relapse. It actually does target the clock and that switch mechanism. So we think that's the most likely culprit. That's the smoking gun, if you like. But how exactly and why exactly it is what it is. We know it has strong genetic determinants. If you're particularly a nighttime person who has trouble sleeping, who tends to do their best work late in the day rather than early in the morning, you tend to have a clock that's a bit more unstable, more easily disturbed. We see higher rates of bipolar type disorders in people who have these so-called late chronotypes, people who generally are night owls rather than morning larks, and people who fall out of shit. And then just an instability in that fundamental biological system. So a lot of the work that myself and my colleagues are focused on at the moment is, okay, what's going on? What's wrong with the machinery of that clock in people with bipolar disorder? And if we targeted that more specifically, would our treatments be more effective?
We touched on that genetic aspect to it, and that leads me to thinking, well, is there much research going into perhaps like the history of how this has kind of developed over time, like the evolutionary aspects? Has it been a part of the human experience, for quite a long time?
Yes. So bipolar disorder is well described ever since humans started writing down about their own experiences. So it has a long tradition. I think in the history of psychiatric disorder, you actually see really interesting things describing disorders that actually persist and don't go away. So people develop them typically in adolescence and really have lifetime difficulties versus those that are episodic. They switch on and off. You know, a person's really unwell for a certain period, then the thing switches off again and they're well again, and then it switches on again and they're unwell again. So this kind of episodic thing, which is really characteristic of bipolar disorder, to be really unwell at certain periods, but to actually be well and functioning at other periods. And it's got its own natural on-off sort of characteristics. So it's been described. So now, if you say evolutionary-wise, I think the reality is our sleep-wake cycle is built in. And therefore, it's been very important. Our sleep-wake cycle has been very important to our survival. And circadian systems, or on-off 24-hour cycles, to exist on the Earth we exist on, you have to have your clock go into synchrony with the normal rotation of the Earth. And across all species, plants and animals, have these systems to some degree. So they've been preserved across evolution because they allow us to survive on this planet. And closer you are to matching your clock to the normal 24-hour cycle. Now, here's a bit of trivia. You know, I'm afraid those people who believe in intelligent design, I've got bad news for you. Our human clocks are not 24 hours, even though the rotation of the Earth is 24 hours. So we have to constantly adjust our clock to the physical reality of the Earth we live on. And the closer you match that, generally the better your health and well-being. So we would posit that the issue is that circadian systems are fundamental to evolution and survival, but in a proportion of us, they're just more unstable. They go off more easily, they're perturbed more easily, and therefore give rise to illness. So a normal clock is essential from an evolutionary point of view. It's helped humans to survive. Be very active during the day, hide and be quiet at night, sleep being a key restorative function to allow us also maximum activity during the day and generally support our health and well-being. But when it goes off, when it goes bad, for genetic reasons, for other reasons, then you're in trouble, and one of the problems you might develop is bipolar disorder.
Because I know, like, if someone is like a night owl, so to say, and they, they're not getting enough sleep, or they're sleeping at odd times, I mean, I can imagine that would alter that, wake and sleep clock. Could that, trigger bipolar in any way? Yes.
So we think those people, you aren't just a night owl just by habit. There are strong genetic determinants whether you are a morning person or a night person. And night people also have more unstable clocks. They find it harder to be in a normal rhythm from day to day. They're less reliable when they sleep. They're more easily kept up by all sorts of other things. Nighttime activity, nighttime light, fun, anything. They have trouble going to sleep. They are more prone to these sets of problems. Now, that's an inherited characteristic, then often made worse by behaviour. So what we often do in the behavioural treatments of these areas is try and encourage people not to try and set up a more regular 24-hour sleep cycle with morning light, regular daytime activity and regular bedtimes, and not be staying up all night. So trying to, in some ways, impose some behavioural discipline across their rather genetic libertarian approach to life.
And do those with bipolar, their wake and sleep clock, is there ever a time where it's, stable, where it's not, where they're not kind of manic or they're depressive, they have that kind of moment of stability?
Well, this varies from person to person. So depending on the severity of illness and how frequently your illness recurs, then yes. Although interestingly, when you study with people with bipolar disorder, when they're well, they're still more likely to be night owl type people, and they're still more likely to have difficulty maintaining a very regular sleep-wake cycle. So one of the things we focus on in terms of relapse prevention is trying to make that stronger and more reliable, both behaviourally, but also pharmacologically or with medicine, particularly those based on melatonin, or which drives the 24-hour cycle and sleep, or lithium, as I mentioned earlier, which helps to stabilise the clock. So really targeting the clock medically and behaviourally to try and make it more stable and less likely to be upset then by life stresses, things that happen, change in seasons, things that would make it more unstable.
Yeah, and I mean, you mentioned lithium there too, how causes the clock to become stable. I mean, do we know why that is?
We do know, well, it's a great story because we've actually known about lithium's therapeutic effect since 1950, when it was first sort of described in Australia. So 70 years later, we think we have ideas as to how it does and its effect on some key biochemical pathways in the clock. So it certainly affects those pathways. There's some ongoing debate as to whether that's the only thing it does or that's exactly how it does it. But certainly we do know now that biochemically it does affect certain key chemical pathways that regulate the clock.
Yeah, I mean, are there any other medications like other than lithium that can kind of cause the same kind of effect?
That's the subject of great investigation. So in the antidepressant area, there are melatonin-based antidepressants and melatonin-based sleep agents, because melatonin is the thing that helps you time your clock to go to sleep every night. That's the thing released by your pineal gland in your brain to regulate your 24-hour cycle. And in work we've done with young people with bipolar disorder, its signalling mechanism seems to be less dramatic and less regular than it is in young people who have other sorts of psychiatric difficulties or in normal young people. So using melatonin in particular looks to be useful, and melatonin-based antidepressants and other areas. And now there's investigation of, well, what do many of our other antipsychotic, sleep medications, antidepressant medications do to the clock? It's true that if you just assist with sleep. So historically, when people were very unwell, the main thing we did was try to get them to sleep at night through sedatives to restore their clock back into a 24-hour cycle in a rather non-specific way. So drugs that assist with sleep, behavioural activities that assist with being active during the day but sleep at night, like physical activity, might all be seen to be potentially useful, but not as specific as some of the other treatments that directly target the clock.
You're listening to Wellbeing, a nationally distributed radio show and podcast. My guest today is expert Dr. Ian Hickie from Sydney University, where we are discussing bipolar disorder. Would you say that this clock is neurological? Is that kind of more what it is?
Yes. So it's a piece of brain machinery. Now, we've known about it for quite a long time, but in fact, people won the Nobel Prize for it about 10 years ago for describing it in fruit flies. One of my great friends and colleagues, a guy called Joe Takahashi in the United States, he should have won the Nobel Prize. He discovered how it works in mammals. And and now we know, so there's a thing that sits behind your eyes called the suprachiasmatic nucleus, which responds to light, and it sets the 24-hour signal. It sends the light signal to the pineal gland, which releases melatonin on time in the evenings in darkness to actually help you switch from your activity awake state to your sleep sleep state in darkness. So tied up with the light dark cycle of the day. So now we know a lot more about the machinery in the human brain that regulates the clock. Now, of course, every time you think you've got something solved in the brain, it turns out it's not quite that simple. So it turns out there are other light pathways affecting mood in addition to those that go through the suprachiasmatic nucleus, or the SCN, the thing that's thought to be the master clock in the brain, which is driven by light exposure through your eyes.
Yeah, I mean, has there been any research or any evidence that supports that the machinery, this clock, is different in those that have bipolar? Like, is there any difference in the pathways?
Such a fascinating question. We know that the output is different. So the production of melatonin is different. Sponsors and changes in light change the issues. There's excellent research coming out of colleagues in Melbourne about different sensitivity, light sensitivity in different people, and whether our various treatments increase or decrease that, make it more stable or not. But in terms of saying any more specifically how it's different, it's likely that in a structural sense it's there, but in a functional sense it's not doing quite what it should be doing in relation to the light and other behavioural signals. And then you ask the question, well, why is that so? Which I'm afraid to say, subject to further research.
Okay. I mean, are we able to like identify, like say with a brain scan, this clock in people with bipolar, and like are we able to almost diagnose bipolar by looking at this clock with a brain scan?
No. I wish it was so, but at this stage, no. Like many brain pathways, we have great brain imaging these days, which looks at the structure of the brain. You know, is everything in the right place? Is something happening? So if you've had a stroke or you've had a head injury or something else dramatic, brain tumour, you can see that on a brain scan. But how the brain actually functions, what it's doing every day electrically and chemically, you don't see distinctly in the type of scanning we currently have available. Now, lots of people and a lot of money's been spent on brain imaging over the last 30 years. And that's been marvellous in stroke, multiple sclerosis, brain tumours, many other areas. But so far in clinical psychiatry, not yet. Functional magnetic resonance imaging, a way of looking at the brain in function, how it uses glucose, how it distributes oxygen, other sorts of scans looking at those issues. We're not there yet in terms of having diagnostic type scans for these kind of conditions. Lots of people hope we will be. Yeah. I think we're more likely to see other tests, blood tests, tests of the responsiveness of the system to light, to other challenges, which will assist us in the future with that diagnostic process. Is your clock behaving normally? Not necessarily is it structurally intact, but what is it doing? And do the treatments that we provide help it to become more stable and therefore particularly prevent relapse in bipolar disorder?
Yeah, I mean, those are some fascinating points too. I mean, do you think it will ever be possible to identify with a brain scan like mental disorders or mood disorders, like in psychiatry?
I think what we'll see is a combination of things: genetic tests, brain scans, blood tests, and other measurement systems that help us to know whether a system's working. So, for example, if you think about something like diabetes, there's a blood test that says, oh, look, your blood sugar's a bit high. Then there's what we call a challenge test. Okay, we'll give you a whole bunch of sugar and see whether you can produce insulin or not. It's a glucose challenge test. And what you find out is that people with diabetes can't produce the insulin. So their pancreas isn't working. So what you'll see in the brain areas, I think, is a lot of challenge tests, other tests that say, look, the brain isn't doing what it's should do in response to the external environment. And so I think those kind of tests actually will become diagnostic tests in the foreseeable future. And perhaps more importantly than just diagnostically, they'll tell us whether the treatment has worked. Have we put, for example, the thing I'm preoccupied with, have we put the clock back into its normal function? Is the treatment we're providing helping to keep it there? So I think not just in a diagnostic sense, but helping us to guide the effectiveness, to know whether we've got the right treatment. And we put the thing that's causing the condition to relapse or persist back in its normal state so you can get on with your life in a more normal way.
In saying that, with this clock and people that have bipolar, is it something that it's not necessarily cured in the sense that it will be returned back to normal forever without any help? It's more something that's managed kind of thing? Yes.
Now, it's an interesting thing. The great majority of modern medicine manages the problem you've got rather than cures it. I think everyone loves the idea of a surgical thing. Oh, my appendix is a problem. Cut it out, throw it in the bin, I'm cured. Or I've got a bacterial infection, give the antibiotics, the bug's gone, I'm cured. Now, that does happen in medicine, but they're actually, in truth, the exceptions rather than the rule. Most other things, we manage the problem. We contain the problem sufficiently to get on with your life. So I mentioned diabetes earlier on, or heart disease, or lung disease, or kidney disease. In many of the other situations, we manage the problem, and we particularly manage the problem early in the course of illness, so it causes less ongoing damage or ongoing problems, so you can get on with your life. So I think managing it effectively, and for most chronic diseases, which is what most of us have most of the time, that's what we're doing.
Would you say just generally with bipolar, is it hard to diagnose at first?
At the early phases, unless it's very clear-cut, severe manic episode when you're young, then typically it is not diagnosed quickly because people typically have anxiety or depression or short periods of activation or other difficulties as teenagers where it is not clear-cut. And people do not rush to diagnose or treat it if they're not certain that that's what it is. So there is often a delay between people's first episodes of being unwell, particularly with depression or with periods of activation or with drug and alcohol use or other difficult behaviour. It's usually some years before it becomes clear that they actually have bipolar disorder. Now, that's not easy because there are lots of people with a lot of those sorts of problems who do not go on to have bipolar disorder. So, it's frustrating for those people who do, who go, oh, I wish this was diagnosed 5 years ago or 10 years ago and it would have done different. What's wrong with those doctors? Why didn't they get it right the first time? Well, actually, they saw 10 other people who looked exactly like you who did not go on and develop bipolar disorder. So what we need is better tests to help us predict who would go on. So the work I'm associated with, again, trying to look at combinations of genetic tests of the body clock, other recordings from people to try our family history, to try and work out in a probability-like way who's more likely to go on to bipolar disorder so that we could actually intervene earlier and hopefully more effectively before they get into much more significant trouble.
And something I think that's very important that we highlight, Ian, is, and especially for those listeners out there that might be going through their own bipolar journey, and that is, from your experience, what can those people do to be successful in getting that stability and being successful in their bipolar journey?
Well, the thing is coming to understand their own clock, their own 24-hour rhythm, their sensitivity to different things, like seasonal change or light change or travel or the use of other drugs or understanding when they're going to risk periods, high-stress periods that disrupt their sleep, or particularly if they're going into childbirth for women or actually for the dads who might be also have their sleep-wake cycles disrupted by new children, understand there are risk periods and trying to stabilise behaviourally in terms of what they do, and then trying to find the right combination of medications that best stabilise their system to reduce the chance of relapse or of very severe episodes. So this is where monitoring your own clock, your own sleep-wake cycle, your own activity pattern, using watches and phones and personalised devices, and making records yourself about where your mood goes up and down or your activity goes up and down, particularly your sleep-wake cycle changes in different hours of sleep versus hours of wake. Trying to learn much more about you and your own clock and what helps to keep it stable versus what tends to make it more unstable.
Well, I want to thank you for such a fascinating conversation, Ian. I think that was, I think we touched on some brilliant things there.
It's a pleasure.
My guest today was bipolar expert, Professor Ian Hickie from Sydney University. Tune in next week when we talk with another bipolar expert, Dr. Noreen Riley-Harrington, in our third instalment in our bipolar series. And if you like this content, check out the Wellbeing podcasts on Apple Podcasts or Spotify for more. Thank you for listening. I'm Jack Hodgins, and all of us at Wellbeing wish you well.